How about now? Can you hear me now? How about now?
Well, it's showing. Wait, it's showing audio.
Okay. So, because the other day, one of them said they were trying to watch it and they couldn't live. So,
Yeah. Because if you look at settings, enable webcast is always enabled.
So are we actually recording?
Yes.
Okay. All right.
Say hi to the class. She's coming, hang on.
Point towards my face, my beautiful face. Thank you.
Okay.
All right. You guys ready? Sorry for the delay. Sorry. We had problems with Tegrity on Thursday, so I wanted to make sure it was actually working today so that anybody who couldn't be at class or all my OPSU students could see it.
When you're done, close out everything, but you'll see the little integrity symbol with the little swirly basketball thingy. Let that finish before you log out.
Okay. All right, got it. So, everybody went home and studied their endocrine stuff, right? And everybody's written all their cash cab questions, right? Yeah. Write them before Wednesday. And remember, your classmates' answers may not always be correct, so I would look them up. This will help you to study for the test. And also, remember, we're going to wear pink, right? And then, okay, listen, it's my turn. During cash cab, I may ask you to do some things that you feel like are a little outrageous. It is your job to do them. Okay? It's your job to do them. No matter what I ask you, you are to do it. So, because part of it is that we want Dr. Pink to come each time, because he is so fun and so amazing. And so the more enthusiasm we show, the more likely he is to come back next time. And also because he and I can get sassy with each other when the whole group's kind of rowdy and it's kind of fun. So everybody's going to wear pink. Remember, if you write your 5 questions, you get 5 points. Okay? If you've written the 5 questions and you come and participate in class, you get another 5. If you don't write 5 questions, right? So even if you come and participate and you didn't write your 5 questions, you don't get any points. Yes, Cindy?
Remind me, is that points after you pass?
Yes, that is points after you pass, which I know is not as fun as points before you pass, but it is what it is, so it's what you've got, okay? What else do you need to know about cash cab? It is a lot of fun. You'll be in clinical groups. It's very competitive. Last time I did it set up in 3-minute increments where everybody had 3 minutes, and I ended up having to stop the clock a lot because I would get tickled with Dr. Pink. So the group that wins will be the group that answers the most questions in their 3 minutes. You can't just shout out the answers though before I've read it. You have to wait until I've read it. And I will stop the clock if I get tickled. I promise. And I will get tickled because I'm telling you, it is a lot of fun. So, all right, let's go on to our second week of focus for endocrine. I know endocrine seems overwhelming. It seems like a lot, but remember it's about your nursing actions. And everything in endocrine, if one thing's high, another one's low, or there's always something that you as a nurse can do to help them out. And so basically when you're studying for this test and you say, okay, these lab values are off, you would go, what would I do about it? Their fluid balance is off. What would I do about it? Their heart rate is too high. What would I do about it? So think about it in those terms, and it'll make it a little easier to study for this test. So, and don't get caught up in semantics. Remember big picture. You know, you definitely have to remember all your nursing actions, and you need to know your labs, et cetera, et cetera. But don't feel like you have to know every detail, because endocrine is too complicated. So it is too complicated. So we're going to basically talk about the last three. We're going to talk about the thyroid, the parathyroids, and the pancreas today. So I know we said this in class on Thursday. Today's Monday, right? On Thursday. If your thyroid is not functioning properly, none of your other glands are going to be able to do their job. Because your thyroid does so much. It's all about your metabolism. It's all about growth. It's all about brain development in peds. It takes care of all your autonomic functions, your heart rate, your liver function, your kidney function. It's your thermostat. So, and you guys know this from MedSurg 1. You know, if your thyroid's low, you've got the dry skin, you're cold all the time, you're constipated, etc. So the thyroid is pretty darn important. And remember, if your thyroid's not working, you don't grow properly, you can't keep your blood sugars up, etc. I mean, it's a big deal. So know your labs for your free T4 and your TSH. I don't know that you need to necessarily know your thyrocalcitonin levels, but it wouldn't hurt. Phosphorus, PTH, those are good labs to know. Now, in adults, typically, after about the age of 35, you should have testing every 5 years to make sure your thyroid's functioning. It's, as we get older, things slow down. And then also, one of the thyroid problems is Hashimoto's, which is an autoimmune disorder. And at any point in your life, you can kind of pop up with autoimmune stuff. And if you have one autoimmune disorder, you're likely to get another. So type 1 diabetes is actually an autoimmune disorder. So people with type 1 diabetes actually have a tendency to have thyroid problems. They have a tendency to have Hashimoto's because that's also autoimmune. And they also have a tendency to have celiac because that's autoimmune. So you can see how they kind of all go in together. Now, your thyroid is influenced by chronic and critical illnesses, and I know we talked about that on Thursday. But someone who is chronically ill will have a depleted thyroid because the thyroid's just working so hard to keep their metabolic processes going. But then someone who gets critically ill very suddenly can end up in a thyroid crisis because their thyroid just gets sapped just like that. Now you think of the goiter as the big knot on people's throats, and a lot of times we think of that as an iodine deficiency, but goiter can actually be caused by overproduction or underproduction of your thyroid hormones, although it's usually overproduction. Anytime someone has a goiter, you are going to make sure you have all your emergency equipment at the bedside because they have the potential for cutting off their airway. So always make sure you've got some sort of airway at the bedside. Okay? Babies born with a goiter usually have a mom who's on thyroid medication for hyperthyroidism. That's usually transient and it'll resolve itself. But in the meantime, those babies are at really high risk for getting their little airway crushed. So you have to watch those babies very, very carefully. And again, keep that airway at the bedside. Those are the babies that you would definitely keep on the pulse ox watch them really carefully. If the mom's sleeping and there's not anyone to watch the baby, see if you can talk the mom into letting you take it back to the nursery, etc. So you want to watch those babies really carefully for respiratory distress. Hyperthyroidism. It's also called Graves' disease. I hate it when they give all these extra names to things like Cushing's and Addison's and this and that. Just call it hyper and hypo. That's a lot easier to remember, right? But remember all these names because you'll see them used interchangeably. But Graves basically is an excess of TSH, which is your thyroid stimulating hormone. And remember, these have an inverse relationship. So whenever your thyroid, when you need more hormones, your brain sends a signal. Your TSH goes, oh, I need more free T4. So it sends that signal out. You make more free T4. When you're done making the free T4 and you have enough of it, the body says, oh, I don't need any more. You can stop stimulating me now, and the TSH will shut down. Most common cause of hyperthyroidism is autoimmune. Again, also the same with hypothyroidism. But you can also have little nodules growing on your thyroid, and sometimes these are malignant and sometimes they're just little growths. But those can also cause hyperthyroidism because they're stimulating that thyroid. And think about it, if you've got nodules on your thyroid, each time you swallow, you're stimulating that thyroid. Each time you bend your neck really hard or stretch it or do this or that, you're kind of stimulating that thyroid, especially if it's really big. So you shouldn't really be able to see the thyroid. So, on really slender people you can, but it just looks like a little butterfly on the neck. If it's enlarged, you can really see the butterfly. But like in a normal healthy person, you don't typically, it doesn't stand out. Okay? So think about it. If your thyroid regulates all of your metabolic processes and it's too high and you've got Graves' disease and you're sending out too much TSH and then your free T4 is too high, what would you expect? You would expect signs and symptoms of an increased metabolism, right? Or increased body functions. So all the things that you can think of that would speed up. So your heart's going to go faster. You're going to have more arrhythmias. They're going to be very restless. They don't sleep well because they're too stimulated. Hyperactive, if you have a kid with hyperthyroidism, they get in trouble a lot in school. And then some people might have trouble in their job for not being able to get things done because they can't concentrate on their different projects at work. The weight loss and fatigue, because their metabolism has sped up so much, they can't eat enough calories to keep going with that. And then obviously very intolerant of heat because their body's going so fast. They've got their own little external heater and they turned the thermostat down in their mind, but it didn't actually turn down. So it's not like you can go over and push the button or turn the knob and turn it down. They're just too hot and they can't stop that process. I don't know why I have hypotension here. I think it should be hypertension. The exophthalmos, have you guys ever seen anyone whose eyeballs were really wide open and really they look like they're startled or surprised, but they look like it all the time? That's exophthalmos. We talk about that other places. Yeah, okay. As long as we talk about it somewhere else. I will tell you the exophthalmos is caused by edema behind the eyeball and increased fatty tissue. The problem with it is that even once you've corrected the thyroid, the eyeballs don't go back in. So once they have that exophthalmos, it's there to stay. Now, what problems can you think of that would come with having your eyeballs bulging, being out, being surprised? Very dry eyes, very dry eyes. So it's not hard to diagnose thyroid issues. Basically, blood work. They're going to check your TSH and your free T4. They'll look for a goiter. They may do an ultrasound or a thyroid scan. They'll listen for a bruit over the thyroid gland because it's getting too much blood to it. And then you'll have positive anti-thyroid antibodies if it's autoimmune. If it's not autoimmune, you won't. I love that picture. Now, I blew her up so she looks even more startled. But even still, she looks pretty surprised, right? I'm sure she would love not to look so surprised, but she is. It can actually impair your vision because all the edema, all that pressure can press on that optic nerve. So the patient may actually have some blurring of their vision, may have some vision issues.
Permanent, right?
Yeah, I just said that.
Oh, yeah.
So, yep, it's permanent. Nothing you can do about it. They are at risk for corneal ulcers because their eyes get too dry or infection. So you want to keep them with eye drops at all times. They may actually have to tape their eyes shut at night to sleep because you really do need to completely close that eye. Or now they have eye drops that have almost like Vaseline in them. It's real thick and it's like an ointment. And that really helps too. But the best thing is, put those eye drops in and then tape their eyelids shut if you have to. One of the other things that you can do is sit them up as much as possible. Don't have the head of the bed flat. So you would elevate the bed or sit them up in a chair or whatever you need to do, because what does that do? It decreases your intraocular pressure, right? Right. It's the little things that you don't think about. And certainly if you're on day shift, it's not that big of a deal. They're probably up, they're probably awake because they're not sleeping, right? They're too wired to sleep. So you've got to think about what can I do to decrease that intraocular pressure. It's just simple things. You actually do want to teach them, to roll their eyes. This is the one time in your life when your mom can't get mad at you for rolling your eyes. No, Mom, I'm doing my exercises. Yes, what you said was completely stupid, but I'm just doing my exercises. So you want them to do their eyes back and forth, up and down, do circles, and teach them to do that several times a day to keep those muscles intact. Again, keep on those eye drops, especially if they're not drinking a lot. And think about it, your processors are higher, so you need to drink more fluids to keep up. They may not be able to keep up with their fluids to the extent that their eyes can stay hydrated. Because if you don't drink a lot of fluids, your eyes get dry, don't they? Yeah. And people who drink a lot of diet drinks have trouble with eye dryness. The artificial sweeteners have a tendency to dry your eyes. So that might also be something you teach your patients with hyperthyroidism. A, they don't need the caffeine, right? B, the artificial sweeteners can cause really bad dry eye. So tell them, warn them away from that. They may have problems with photophobia, so light may hurt their eyes. So they'll wear their granny glasses with the cool wings on the side. Yeah, I'm about a year away from those. They may have salt restrictions because what does salt do? No? What does salt do? Retain fluids. You retain fluids. So that may increase that edema. So even though they may be fluid deprived here, it may not be going to the right place because the salt encourages it to stay in the cells instead of circulating where it's supposed to go. Sometimes they may have to do surgery to correct it once they've corrected the thyroid, but that's pretty extreme. Usually they just try to manage it symptomatically. All right. Where did I put? See that restless, inattentive, hyperactive there? The person with severe hyperthyroidism that has been misdiagnosed, if it's really severe, may actually be misdiagnosed as being manic. So they have to make sure that they get their labs in before they diagnose someone as manic, because it can completely be something else. So, nutrition for the hyperthyroid patient. Let's see, I'm burning more calories, I need more fluids, I need high protein, high calorie. What in the world am I going to do? Seems like common sense, you would think. But, high calorie diet, 4,000 to 5,000 calories a day. This is my dream disease right here. Big Mac, I'm coming, baby. 6 full meals a day. So, yeah. I mean, that's a lot. That's a lot. Now, okay, I know people who can eat 4,000 to 5,000 calories in one meal if they sit down and do the supersize and the this and the that and the other thing. So you might not quite need those 6 full meals depending on what your idea of a full meal is. You want your snacks to be high in protein and carbs. Got to have your vitamins A and B6. Niacin, thiamine, very important for thyroid function. It's pretty important for everything. You'd be amazed how much all the vitamins and minerals that we talk about are important.
Did you say niacin and thiamine?
Well, niacin is B6.
Okay.
So what happens if you, have you ever seen anyone who gets a reaction when they take B6? They get that flush. They'll turn beet red from their head down, and it kind of like a menopausal hot flash. Feel a little bit like they're about to burn up from the inside. It doesn't last real long, but if you might want to warn people, there's another education tip for you. Okay, I'm going to give you this niacin, because a lot of times it goes under the tongue. It's intense because you have under the tongue is so vascular. So tell them, okay, you may get a little bit of a flush from this. So
You give them aspirin, is it supposed to be
it's not that big of a deal. Yeah. So avoid highly seasoned foods. Why would you do that?
increase and stimulate their gastric.
Right. Their GI is obviously very irritated. They're probably going to have diarrhea. They're going to have an upset stomach because everything's moving faster than it should. So highly seasoned foods are going to irritate that stomach anyway. You want to avoid caffeine. Believe it or not, you want to avoid fiber. Probably the only diet where they tell you to avoid high fiber. But because your GI system's already overstimulated, the fiber would just stimulate it even more. So again, if I had to have a disease, this could be it. So, except it's pretty miserable. I say that, but it's pretty miserable. All right, treatment. You've got your anti-thyroid medications. Basically, the tapazole and the PTU, they block the hormone production by preventing the iodine from binding to your thyroid gland. So basically, they're just blocking all that. They decrease the size and the vascularity of the gland. So if someone's going to have surgery to remove their thyroid because they're hyperthyroid, they'll give them tapazole or PTU because that helps with postoperative bleeding. The thyroid is pretty highly vascular, so postoperative bleeding is one of the complications that you have to really watch for. The tapazole and the PTU just help decrease the problems with that. Tapazole does cause birth defects, so if you have a hyperthyroid patient who's pregnant, that's one of the no-nos. I think so. Yes. Beta blockers. Can you guess what beta blockers would do?
Slows down.
Yep, they're just going to slow down that heart rate, decrease that blood pressure.
Help with anxiety.
Lithium. Remember, lithium can destroy your thyroid? Yeah. And your renal, that's right. Good job, honey. So sometimes they'll give lithium if they can't get that thyroid under control. Interesting, huh? You got your beta blockers to help with the symptoms. Then the iodine just helps. Let's see. I went past myself. Look, I have to look at my notes today. Sorry. On all your thyroid medications, like your Tapazole and your PTU, make sure you space them out real evenly. So if it says 3 times a day, make it every 8 hours, not whenever you remember it, because you want the dosing to be pretty even so that your hormones level out a little bit more. You do have a problem with being at risk for infection with the Tapazole and the PTU because they decrease your white blood cell counts. So you want to monitor for infection with that. Both of those can also cause liver failure. So you want to monitor for jaundice, any signs of like dark urine, any signs and symptoms of liver failure. They may have increased bleeding, so watch for bruising, watch for petechiae, stuff like that. Now, too much of it can put you into hypothyroidism. So if they go from one extreme to the other, you need to call the doctor and say, hey, can you regulate my meds a little bit better? Because now I'm too slow. So they go from one extreme to the other. Let's see. The atenolol, I would do this with the propranolol too. Take a heart rate before you give them the med. Remember, if it's below 50, you're going to hold the med, call the doctor. Yeah, I would go with 50. I can be below 60. If I'm resting, I can hit below 60 easy. So, can anybody in here regulate their heart rate for me? I can actually slow my heart rate down. Can you? Yeah.
I do it when I go to the doctor's office, and they're like, "Why is this so low?" I'm like,
I don't know.
"But I can do
Yeah.
it." It's good.
Yeah, I can get my blood pressure down too. So, not everybody can do that, but I can do it. So, for the atenolol, have atropine available in case it is too slow, so you can reverse it. And then, of course, they're going to be on heart monitors. Because they may be going too fast. They may have cardiac arrhythmias from the actual disease process, but then the meds you give them also have cardiac implications. So they're probably going to be on a monitor. If they keep having tachycardia in their outpatient, that probably means they're non-compliant, or they need a dose increase. So here's a tip and a trick. If a patient says, I swear I'm taking all my medicine, I am, or if you have a parent and the kids are small, I'm giving it to them every day, you can call the pharmacy and say, hey, when was the last time they had this medicine refilled? If it's been 2 months and you only gave them a 30-day supply, you can bet your bottom dollar they're not taking their meds. So, now, if you're a grown-up, you get to make your own choices, right? But if you're a little kid, you kind of need your parents to stick by you on this stuff. So, because the thyroid is so dangerous to mess with, if it's undertreated and they're less than 3, they can actually sustain brain damage. So, because the brain is really, really dependent on the thyroid. So it's another one of those tests that they do when you do the newborn screening, and it'll come back really quickly whether or not the baby's thyroid is functioning properly. You have to have treatment before about 14 days of life or brain damage starts. So I'm sure that some of the mental retardation that we've seen in the past was just because they had hypothyroidism and it was undiagnosed. But it's very important, especially in little kids, for brain development and growth and etc. So, the iodine, basically don't mix that with your antithyroid drugs. So if they're on iodine also, give them their antithyroid drugs, and then an hour or so later, then give them the iodine. Okay? They just don't blend well together. One cancels out the other, or potentially, I can't remember. Don't give them together. That's what Mama said. All right? It also decreases blood flow to the thyroid. It can cause hypothyroidism. The big deal with the iodine is it takes about 2 weeks for it to take effect. So you still have your tapazole, you still have your PTU, but then you give them the Lugol's or the SSKI, and in about 2 weeks it's going to start to kick in. So you may have to decrease the doses of the other in about 2 weeks when this starts taking effect. Now the iodine will stain your teeth, so you always want to have them drink it through a straw. You want to give it after meals. Initially, the iodine can actually cause an increase in your free T4. Because the iodine is how the thyroid works, right? You have to have iodine for the thyroid to work. So then initially, it may create a surge. Now, if they're on the iodine, you're going to check them for iodine toxicity. Because again, just like so many other things, there's a fine line between not enough and too much. So you're going to look for swelling of the buccal mucosa. So around their mouth, look for swelling. And hope that they didn't have bad gingivitis before so that you can actually tell, right? If they're slobbering too much salivation, that may be a problem. They'll have nausea and vomiting because they're toxic. They may have some sort of weird skin rash going on. If this happens, call the doctor. Stop the medicine, call the doctor. Okay? Now, like I said, iodine before surgery also helps decrease that risk of bleeding after surgery. Helps decrease that vascularization. So if I've told you this 3 times, there's 3 medicines that help decrease vascularization, right? Less blood flow to the thyroid means less thyroid hormone put out. If they're going to have surgery, it means less risk of bleeding. So what would be one of the main things you would look for in the patient post-thyroidectomy? Bleeding. Exactly. All right. Where would you look? Behind the neck. Behind the neck. Because if they're bleeding and they're laying down, it's going to just trickle right around that bandage. Gravity's your friend. It can. It can be inside, but gravity is your friend, or not your friend in this case. And it's just going to trickle right around to the back. So put your gloves on and slide your hand behind their neck to check for bleeding. Simple, but something you wouldn't have thought of, right? Exactly. All right. Radioactive iodine uptake is probably the most common treatment for hyperthyroidism. They will try you on the antithyroid meds, but people a lot of times don't want to take them forever. They don't always work real well. The radioactive iodine works pretty well. There are people who choose not to go on it or who choose not to do it because you do have a higher risk of cancer later on down the road. I would say that most people probably don't inform themselves well and say, okay, I'll just do that one. It's kind of it's a hard decision. You know, you can take these medicines, which have some serious potential side effects, liver damage, right? Really messing you up. Or you can have radioactive iodine. Just the word radioactive. Sounds like a bad idea, right? But it does just go straight to that thyroid, so that really helps. The thyroid will pick up that radioactive iodine, and then it destroys the cells that produce the hormones. Now, the iodine does cross the placenta, so you have to make sure that they are not pregnant, because that would be bad. That would destroy the baby's thyroid also, right? If they're going to have the radioactive iodine uptake, you've got to discontinue their thyroid meds about 2 to 3 weeks before. Otherwise, you have too much in your system. It does take about 2 to 3 months for it to take full effect. So they may have some hyperthyroid issues in the meantime. What's really going to happen is that after this, you've basically ablated their thyroid. So now their thyroid is probably toast. It's very likely that they're going to have to go on thyroid replacement therapy now. So it doesn't always work, though. I mean, I've had patients that have had to have the iodine uptake 2 or 3 times before their thyroid quit putting out too much hormone. So it's kind of a, you do it, you wait and see if it got rid of enough of it, and then you may have to do it again. But typically what happens is that it works, and then from then on they're hypothyroid. But hypothyroid is easier to manage. So when you have to choose between the two, you choose hypo. Now, I know I said you have to discontinue the drugs before you do the radioactive iodine. However, once you've done it, because it takes time for it to actually kill that thyroid, they do need to go back on their antithyroid meds until everything has kind of leveled out. Now, it says that it's a minimal radioactive risk. You can be around people. You don't have to cloister them in a room or anything. But then it says avoid holding babies. Avoid being around infants. Don't be kissing on babies. So,
For like a day, right?
about 3 days. And that's mostly because children are more susceptible to radiation. So whereas we're grown-ups, we can handle it. Our bodies are just a little bit more stable. Babies are not quite as stable. Plus, if you're holding a baby right here, and you got their little head right here by your neck, and you're radioactive right here, you're right by their little brain. Let's just go with no. Okay? Let's just be careful. Safety. Okay. So, thyroidectomy, not that big of a surgery as far as it goes. They will look like someone tried to slit their throat. They'll have a little cut just right across here. And at first it'll look red and it'll look puckered and it'll look angry, and they're, especially if it's a girl or a young woman, they're freaking out because they're like, oh my God, this is going to be awful. I'm going to look like this the rest of my life. But when you're talking to them, do a little reassuring with your patient and say, this is going to fade. In about 6 months, it's just going to look like your little neck wrinkle. Because they basically go right in there with that wrinkle. And in about a year, you won't even notice it unless you know. So they might, if they've got a really good tan, you might see a little white line. But it really does fade very quickly. And the redness and the puckering and all that goes away pretty quickly. You're only going to do the surgery if they are unresponsive to the meds or can't take the meds or don't want to do the radioactive iodine, or if their thyroid is so big that their trachea is being compressed and you don't have time for all those meds to kick in. Make sense? So if it's already compressed and it takes 4 to 6 weeks for these meds to really work and shrink that thyroid, you may not have that kind of time. Obviously, malignancies, again, those are not horribly common. And the nice part about it is when the thyroid is malignant, it usually stays encapsulated in that area. It's not one of those that just goes running off everywhere. You've got a little bit more time than you might with some of the other cancers. One of the complications of hypothyroid or of thyroidectomy is that your parathyroids sit right on top of your thyroids. And they're teeny. And they're hard to see. And when the surgeon's in there taking out your thyroid, he might accidentally take out your parathyroids. So, what can they do about that? Well, when they take out your thyroid, if they've accidentally taken out your parathyroids, they take a good look at it before they send it off to pathology. They sit there, they look at it, they go, yep, took out the parathyroids, bummer. What they do is they basically just make a little incision in your arm right here, and they stuff your parathyroids back up in there, and they keep working. Isn't that amazing? I mean, apparently they just need a good blood supply. So you could think of the parathyroids as little parasites. They don't really need the thyroid to function. Yeah, they just shove them right back up in there, sew you back up, and they keep working. So, now the only problem is this, if the surgeon doesn't notice it, right? Now, ideally, you want to leave them where they grew, where they started off, but it's not the end of the world if they don't catch it, as long as they put them back in. Go figure, huh? One of the other big problems is hemorrhaging, because remember, this is a very vascular gland. So maybe they haven't had time to get all those meds in you to shrink it, to get the vascularity of your gland shrunk. So you're going to really watch for hemorrhaging. So again, put on your glove, run your hand around the back of their neck. If it's dark, get your flashlight. Has anybody been to Lowe's and gotten the safety goggles with the lights on the side? They're amazing. You go in your patient's room at night and you flip on your little lights. You don't have to flip on the big light, because let's just face it, that's mean. Okay? And wherever you look, the lights go with you. So you can assess their IV, you can look at the glove on your hand, you can tell whatever's going on with them without flipping on every light. So, yeah, the only problem is if the patient's trying to look at you, they can't see you. All they can see is those lights coming at you. So it's kind of like the train coming out of the tunnel. Yeah. Sometimes they'll go, "Who is that?" So, you may injure their laryngeal nerves. So you would expect a little bit of hoarseness the next day, but continued hoarseness or really, really sore throat on swallowing could be permanent injury to that nerve. So you want to watch for that. Let's see. Oh, vital signs every 2 hours. Do I have that in? Oh, look. Vital signs every 2 hours for 24 hours. Because you're watching for tracheal compression, you're watching for thyroid storm, you're watching for hemorrhaging. So, obviously vital signs are a big deal, right? All right. Semi-fowlers, and you want to make sure they've got a good pillow behind their head. If they don't have a pillow behind their head and they're doing this, what are they doing? They're stretching that suture line, which increases your risk for hemorrhaging, which increases that scarring. It's just a nice thing. Put a pillow behind the head. Tetany. You guys know what Chvostek's sign is? Thought I had that in here. Must not. Okay. Chvostek's sign is very cool. You tap on the bone right here.
This is what that is.
No, Chvostek's sign. Tetany is hypocalcemia. So, say they accidentally took out those parathyroids and they didn't catch it, right? Or say the parathyroids got irritated and quit working for a day or two. So you're just going to tap on their little cheek, on their bone, and if you see their mouth twitch, it almost looks like they're sneering at you, but it's involuntary. And you'll just see a little twitch right around the mouth. That's a sign of tetany. So that means that their calcium is too low, and they're going to need a little supportive help with that. Get them up and get them walking as soon as possible. That way you know what's going on with them. You'll notice whether they've got anything too high, too low, too this, too that. Fluids, want to make sure they can swallow okay. Soft diet, again, it seems like common sense, but I have to tell you all this just in case. Talk to them about the body image. What would be therapeutic communication? If someone said, "Oh my gosh, I'm going to have this horrible scar the rest of my life," what would you say? Don't say, "Honey, I got a scar this big and this wide up my thigh. This is nothing compared to it." Is that therapeutic? No. No. Do you say, don't worry.
No.
Yeah, because even though that's what we all really say, or all we really want to say, what you really want to say is, that scar's going to fade. In about 6 months, you'll hardly even notice it. It'll just look like that wrinkle. It will get better. If you can pull up pictures so they'll believe you, even better. Hyperthyroidism is not so uncommon. So a lot of people know people who've had it done. But occasionally you get someone, especially if they're young, not a lot of life experience, who hasn't seen it. And so they are pretty much freaking out. So. And then, of course, if it's close to Halloween, you can say, hey, look what you can do. You can go as Frankenstein. Don't do that. I'm just kidding. Not therapeutic. If I tell you something and it doesn't sound therapeutic, it's because I probably said it at one point in my life.
Although if I was your friend and you said that, Sharon, I would laugh.
Good. Okay. I spend a lot of time getting my foot out of my mouth. So, basically, if you want to know what not to do, just come talk to me. I actually was doing home health care at one point, and I had a patient who was very, very sick, and she was dying. And I went to see her, and her husband said, she's just slipped away. And I thought he said, she's just slept away. And I said, oh, good. And he got this stricken look on his face, and I said, let me back up. What did you just say? And he said, she just slipped away. She passed away. She's gone. He's like, I'm so sorry. Yeah. What not to do? Right here. Right here. Okay. That's me. Yes.
In the book post-op, it said that you need to monitor vital signs every 15 minutes until they're stable, and then every 30 minutes.
For how long?
That's it. That's all it said about
Okay.
vital signs.
Typically, when they come to you on the floor, every 15 minutes for the first hour, and then every 30 minutes for usually another hour, and then it'll go to every 2 hours for 24 hours.
Okay.
So, all right. Make sure I've got everything. So, we talked about, did we talk about this? I don't remember if we did or not. We will talk about it. Thyroid storm. After the thyroidectomy, if they have a temperature increase of even 1 degree, go tell somebody, because that could be an indication of thyroid storm. Now, chances are, if their temperature's up 1 degree, their heart rate's probably up. Other things are probably up, but monitor that really carefully. Because, with other surgeries, a temp of 99.6, 100, you don't worry about it so much because you think, if I can get them up and get them moving, or if I can get them to turn, cough, and deep breathe, that temperature will go down. But with this one, you actually have to be really proactive on that, on the temperature, okay? Monitor for respiratory distress. Emergency equipment at the bedside. Check that before they come to your floor. Do not wait until they come to the floor. If you know you have a post-thyroidectomy patient coming to you, make sure you have emergency airway equipment at the bedside before they get there. If you have to suction, gentle, very gentle. Don't go ramming the catheter all the way down their throat. Just get as little as possible as you can just out of their mouth. Again, talking might be hard for a couple of days, but if it's persistent, that may be indicative of nerve damage. Okay? So they're at risk for impaired swallowing, right? So you want to make sure you watch for that. Disturbed body image. Okay. Pain meds. Hang on, Catherine. Pain meds. Give pain meds around the clock. Because if they're hurting, they might be straining at the incision. It also enhances your ability to swallow if you've got pain meds on board. Who's had a tonsillectomy in here? I mean, do you remember you were scared to swallow because it might hurt? And so you didn't swallow, which actually exacerbated the problem because that made you dehydrated, which made your throat more dry, which made... It's all one big thing. Same thing with this. If they're afraid it's going to hurt, they won't swallow. And then they might get dehydrated, might have more problems. Your priority assessments are their airway, checking for tetany. If they report any tingling around their fingers or toes, that's also a sign of hypocalcemia. So you're going to make sure also before they get there that you've got calcium gluconate on the unit or close by. Okay? See, I always think, maybe I skipped this part. This is important, but then I don't find it. So, calcium gluconate. How fast do you give that? Over 10 to 20 minutes. You don't slam in calcium gluconate. Why? Cardiac implications. Absolutely. So, usually it's in a bag. You hang it, put it on your IV pole, tell it how long to run in over. Yes, ma'am.
How long do you give it?
10 to 20 minutes. Okay. All right, thyroid storm. So we haven't been able to get our patient under control. If the medicines haven't worked, or it's an urgent case where maybe they waited too long to come in, and they're in thyroid storm. Or say, some goober decided, oh, look, their thyroid's really big. I think I'll manipulate it. And they cause a thyroid storm because that causes a release of all those hormones. So, thyroid storm. As you can imagine, everything is up, right? Can lead to cardiovascular collapse and shock because your body can't keep doing it. Your heart just can't keep going 180, 200 beats a minute. It gets tired. It's a muscle, right? So, obviously, got to take care of it. This is life-threatening. Their free T4 is going to be through the roof. Normal is 60 to 170. Theirs is going to be really high. Free T4, that is not right.
Yeah.
That is not right. What?
Free T4 is 0.8 to 2.4.
What is 60 to 170?
T3 is 70 to 205. T4 is 4 to 12.
I don't know where that number came from. Scratch that number out. So, yeah. Free T4 is going to be through the roof. So, I'm sorry? I don't know.
0.8.
Life-threatening. Danger, Will Robinson. Danger. Danger. Severe tachycardia. Hyperpyrexia. Anybody figure out what that means? Fever. Really high body temperature. Really, really high body temperature. Shock, restlessness, seizures, nausea and vomiting, diarrhea. Why? Because their GI system is overstimulated to the extreme. They may be delirious. They will eventually lapse into a coma. So what are you going to do? It's all symptomatic, right? You're going to do what you can to get their fever down. You may have to put them on a cooling blanket. You're going to give them the propanolol or atenolol to get their heart rate and their blood pressure down. The steroids are going to help their body to fight any inflammation. Antithyroid drugs. This is when you've got to really check those ABCs, the airways, the breathing, the circulation, because it does have cardiac implications. Obviously, it could have breathing implications if their thyroid's too big, right? So you want to make sure you look at that. Obviously, if I'm sending you to a chart in your book, you should look at it. That's my hint. All right.
You said that again, Sharon?
You're so funny, Nikki. If I'm pointing you to a chart in your book, you should look at it. Why is that? Yeah. And if I say it more than twice, it's probably important. Yeah. Hydration, 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 hydration. So IV fluids. Sure. Yes, I would remember that. Hydrate, hydrate, hydrate. All right. Remember, you're treating all the symptoms. Until the doctor gets it under control, you're treating the symptoms. And obviously, education is important. So have you ever had the doctor give you a medicine and you didn't know what it was for and what it was about, so you thought it wasn't really important, so you didn't take it? Yeah. Then you don't. So after my hysterectomy, I went back about 8 weeks later, and the doctor said something about, because you're not supposed to lift more than a gallon of milk and this and that and the other thing. And of course, did I listen? No. I had my surgery on Monday. I went back to school on Thursday. That's, staying home's for wimps, whatever. Sleep when you're dead, etc. So I went back, 6 or 8 weeks later, and he was like, "Oh, good, you did a good job. You didn't lift, blah, 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 blah." Because it's really a problem when your guts fall out. I was like, "Oh, you didn't tell me that was why I shouldn't lift." I might have listened a little more if I had known. Because I just thought, you're sore. Maybe the muscles have been cut. You got to heal there. But no, it was actually, you don't want your guts to fall out. Okay, we're good. So teaching is really important because you want them to know why they need to take this medicine. Just saying, this is going to help slow down your heart rate, this is going to help you sleep a little better at night, may not do it. But saying, your heart's a muscle, it can only run this fast for so long, and then it's going to stop. And again, you can say that a little more therapeutically, right? Yeah. Direct works really well for me, but not for you guys. Yeah. They're more likely to take it if they really truly understand why they need to take it. That's all I'm saying. All right. Any questions that I can answer? Yes.
My book says that iodine can trigger violent storm and hypothyroidism. So why do you give iodine to treat it?
Drug is it different than dietary?
Because what happens is the thyroid takes up all that iodine, and eventually, once it has enough of it, it will block any more thyroid hormone from being put out. But in the meantime, you're at risk because the more you put out or the more you take in, the more likely you are to put more out. So that's why they have to be on the other drugs also. That's why they have to be on the Tapazole and the PTU, because those will help counter effect that. Because initially you may see a surge of hormones with the Lugol solution, but then in about 3 weeks it's done its job and it's starting to help recede the surge of hormones. So, can I answer it? Are you sure?
Yeah.
Okay.
For someone that has hyperthyroidism, you're monitoring directly after surgery for increase of temperature of 1 degree. Would you, for any hyperthyroid patient, no matter what, be monitoring for that same temperature increase?
Okay, I'm going to admit I wasn't listening. Can you say it again?
So you said after a thyroidectomy you would monitor for an increase in just 1 degree temperature, and that would indicate that you might have a problem.
Right.
Would you be that vigilant about anybody that had hyperthyroidism, or just?
Well, with hyperthyroidism, remember, they may have a fever anyway because their thyroid is too high. So.
Just a major concern after post-thyroidectomy.
Belly. Sorry, that was my belly. No, because afterwards you should normalize, right?
Right.
Okay. So a temperature increase might indicate fever or the storm coming back or whatever. So does that make sense?
So only after that surgery, is that when we're only worried about the temperature increase of 1 degree, or is there other reasons that we have a temperature of 1 degree?
If you're in thyroid storm, you're going to have temperature increases, and you're going to be monitoring their vital signs very carefully. Now, but here's why I said that. If they were not in thyroid storm before you did the surgery, and then they come back from the surgery and their temperature's all of a sudden higher, that indicates they may be in thyroid storm.
So it is just after the thyroidectomy that we're vigilant about that.
Yeah. I mean, you're still monitoring their temperature after or before, and obviously if it's high, you're doing things to bring it down. But a temperature increase after the surgery can indicate thyroid storm.
Okay, thank you.
Okay. Shh, my turn. How much time do we have? Okay. Hypothyroidism, low. Oh, sorry. I'm a little giddy. I only had like 4 hours of sleep last night. Hashimoto's is autoimmune. It's the most common. Again, it goes in with other autoimmune disorders, but just because you have one doesn't mean you're going to have the other. It just means that typically if you do, they'll test for the others. Congenital hypothyroidism, we talked about that. You can be born with a low-functioning thyroid. Every once in a while, that thyroid will kick in somewhere between the age of 2 and 3, and they'll be able to come off those meds, but most of the time, it's a lifelong treatment. And again, it has to be treated or they will have brain damage. DHS will take your children if you do not give their thyroid medicine. I mean, they'll be just like that. They'll be like, no, you're causing brain damage on what would have been an otherwise normal child, and they will take your children. So, now, why would you have acquired hypothyroidism? From surgery, from them taking it out, right?
Or could you have it from like having a hypothyroidism and then taking medication?
You could have it, yeah. You could have it from lithium. You could have it from chronic disease states where it wears your thyroid down. There are other reasons. Basically, think of your metabolism as being so slow you feel like, oh, I can't move. So, very, very tired, often constipated, irregular menstrual cycles, hair loss. Your fingernails may flake. You'll notice that your fingernails flake a little bit. Very dry skin. No matter how much lotion you put on your skin, you got alligator legs. Cold all the time. Cold, cold, cold. But you kind of care, but you can't get up the energy to get real upset about some things that maybe you should get upset about. It is such, it can be diagnosed as depression. It is so easy to treat hypothyroidism. All you need is levothyroxine, Synthroid. Easy enough to treat. It has to be watched for a while because usually they'll start you off on one dose and then about a month later they'll get labs, check that free T4, TSH, see where you are on it, and see if they need to adjust your dosing. Now in pediatrics, obviously that dose has to be adjusted pretty frequently. So those kids have to be seen every 3 to 4 months, especially when they're infants, because they outgrow their medication very rapidly. But then as adults, we pretty much get, into a kind of a pattern. We're at this weight, we're at this, we're pretty stable. So typically, once they get you stabilized as an adult, you can go in every 6 months or so. Every 6 months, even a year. Some doctors will go a year. What would your signs and symptoms of over-medication be? Signs and symptoms of hyperthyroidism, exactly. Again, it's one of those things like, did I need to say that? But then I think, well, if I didn't, you wouldn't put it. You might not put it together.
You need to say everything, Sharon.
Everything. All right. So, if they can't swallow pills, it doesn't dissolve well in water. So you can crush it up. You can put it in applesauce or milk. However, you cannot put it with soy. Soy nullifies the effects of levothyroxine. So say you do have an infant, but they can't tolerate regular formula and they're on soy formula. So what do?
With applesauce.
They're a baby. They're newborn. Mix it with water, stick it in the nipple. Remember, you would never put it in the whole bottle. Why? They might not get all of it. That's right. They might not take the whole thing. So you just put a little bit in the nipple with a little bit of 10 cc's of water and suck it down. But don't give it with soy. And you also need to give it 30 minutes before you eat or so. It's better on an empty stomach. So with a baby, that could be kind of challenging, right? Sometimes little babies like to snack all day long. Just make sure it's been at least 2 hours since they ate, and then about 30 minutes before you think they're going to get hungry again. It gets easier as they get older. It's better to give it in the morning. It's not completely mandatory to give it in the morning, but can you think of why it would help?
Gives you energy.
Okay.
Your metabolism.
Yes, because it increases your metabolism, it gives you energy, it helps you get through the day. If you take it at night, you might have a harder time sleeping, you might have a harder time getting together. Now, I know people who take it at night and it doesn't bother them a bit, and that's fine, but it's preferred to take it in the morning. All right. Myxedema coma. Severe hypothyroidism. Basically happens if you're untreated. Remember we talked about chronic or sudden illness could deplete your thyroid? Well, sepsis really sucks the life out of your thyroid. So the patient who is septic may really need some thyroid help. So hopefully the doctors are running tests on them pretty routinely if they're septic, to check and make sure that thyroid's still functioning. It can be caused by drugs, the lithium, any overdose type stuff. If you're already hypothyroid and you're not where you need to be on your medications, exposure to cold can trigger this. Severe trauma, acute illness. Even when treated early, it has a greater than 50% mortality rate. So, well, I say that. It has a greater than 50% mortality rate. If it's treated early, it drops 5% to 45%. So, you can see how letting it get to this far is really a problem. I can't say that this is real common. This is not real common.
So, Sharon, you're not going to see this. If there's going to be pre-existing history somewhere. You're not just, I'm not going to get in a traffic accident.
Not you.
Right.
Unless you've got, probably not, but
there's some kind of pre-existing something first there.
yes, but you could go into the hospital
Fine.
septic and not have had thyroid problems in the past, and yes,
Okay.
you could, but it's unusual. But chronic stressful illnesses, severe traumas, things that really just deplete your body of that energy can cause this.
I have a patient that had it.
You did? Really? And why did did they not take their medicine? What was it?
They don't know. They really don't know, but it was in the ICU, so she was pretty sick. Anyway,
Pretty sick.
They kept testing her TSH level, and it was like, no.
The TSH was going up, but the free T4 wasn't, right? Right. So, because what does that TSH do?
It was at like,
Stimulates the thyroid.
it was at like some crazy number.
Yeah. All right. So by the time you see them, they are very sick. Right?
Yes.
Is that right, Haley? They're going to be swollen. Their skin is going to be very thick. You see this lady? She basically looks like, that is a lady, and she doesn't look like she's got a lot going on up there, right? She probably doesn't. She can't think. She cannot think. Her brain has slowed down to the point that she can't think. She can't shut her mouth. Her tongue is swollen. It's thick. Their legs will be pretty big, real shiny, no hair on them. Almost like, cardiovascular disease, how their legs look like that, but without the dark spots. Severe drop in their vital signs, low heart rate, low blood pressure, low respiratory rate. They're going to have a blank expression, very slow movement. You may not be able to understand them. It may be mistaken for drug or alcohol abuse. Someone may just think, oh, she's drunk, I'll throw her in the drunk tank overnight. It'll be all right, but it could just be this. It does lead to a coma if it's untreated. You got to have 3 or more of the following in order for it to be the coma. Which you would think the coma itself would be the differential diagnosis, but maybe that's how they get there. Maybe you're unresponsive to the point that they start running all this stuff and your blood sugar's low, your sodium's low, your heart rate's low, blood pressure's low, everything is low. Their breathing may slow down to the point that they have to be on a ventilator. They definitely have to be on cardiac monitoring. The Synthroid has to be IV. Why? Exactly. Their gastrointestinal system has shut down. So you can swallow it, but it won't do you any good because you're not going to digest it. You're not going to take it. So the levothyroxine must be IV. If their saline's low or if their sodium's low, obviously hypertonic. Monitor, monitor, monitor. Did I say monitor? Okay. And check and see where they're going as far as their weight, their eyes and nose. Are they getting enough fluids? It's all about the support. Got to get them over that hump until that levothyroxine starts working. Yes, ma'am. I can't hear you. Maybe. Depends on the temperature. You might have to have a warming blanket. So you might warm their IV fluids. Have you ever seen that? You can warm the IV fluids. Parathyroids. Okay. So we just talked about them a little bit, right? Right above the thyroid. Oh, can you guys hold on 10 more minutes before we take a break? Oh my gosh, no. Okay. Go take a break. 10 minutes. Be back. All right, and we're back. You ready? Okay. Remember that? How many people were cheerleaders? Ready? Okay. Oh, somebody let in the poor loser who was late. Oh, not therapeutic. Okay. What not to do, right? My turn. Can somebody shut that back door? Pull it until it snaps. There you go. All right, so your parathyroids, right on top of your thyroids. Go figure. That's the name. Increases your calcium absorption. Promotes your bone reabsorption of calcium. Remember, anything in your body like this has an inverse relationship with something else. With your parathyroids, it's phosphorus. So if your calcium high, your phosphorus is low. If your phosphorus is high, your calcium is low, right? All right. What are we diagnosing? Oh, okay. So anytime they think there may be a problem with your parathyroids, they're going to basically take labs. They're going to check all these different things for calcium issues. How complicated was that sentence? Not very. Has anybody ever seen the DEXA scan? It's just a giant X-ray table, but it's really low on the X-ray spectrum, so it's not considered one of those that's really harmful, but you still have to do a pregnancy test if they are of that age, and just checks for that bone density. CTs, MRIs, ultrasounds will reveal bone issues. Okay. So with hyperparathyroidism, basically you have an increased secretion of your PTH, which is parathyroid hormone. Go figure. Most of the time it's caused by some sort of a tumor on the thyroids. It can be secondary to renal failure, or even long-term dialysis can cause your thyroids parathyroids to mess up. They will have fragile bones. They may have kidney stones. They may have frequent urination, abdominal pain, fatigue. All these stem around that calcium loss. So if you think about it, because remember, if your kidneys can't flush all that out, or if the calcium's too thick in there, you're going to end up with the kidney stones, right? They may have depression or forgetfulness. Maybe that's what's wrong with me. I self-diagnose every week, don't I? Frequent complaints of illness with no apparent cause. They can't figure out what's going on with them, and it's this simple little bitty gland. They can have severe implications from this. You could have renal failure, pancreatitis, fractures. Fractures are probably the most common thing. They keep breaking things and can't figure out why. They bump into a door and break their arm. Very, very, very easy to fracture. Now, with the hyperparathyroidism, obviously surgery is necessary. You have to get rid of that, right? So then they're going to become hypo. So if you have a rapid reduction of your chronically high calcium levels, you can have tetany. That's exactly right. Cardiac changes and tetany. Why do I have that? I hate it when I can't remember my notes. I'm going to let you come teach this class. So, okay, so obviously if it's hyperparathyroidism, diuretics are going to help get rid of the extra calcium, right? Makes sense. The bisphosphonates, those are the once a week or even once a month drugs that help to help you to absorb that calcium. We actually give bisphosphonate IV, pamidronate infusions for patients with osteogenesis imperfecta. It helps their body to just absorb that calcium. It basically coats their bones, almost like steel, but I mean not that strong. Pamidronate also has the problem that if they have too much of it in too short amount of time, it can make their bones fragile like glass, so they can actually shatter. So while it can help, you have to really watch those levels very carefully. They only give pamidronate if you really do have severe osteoporosis. It is very painful. It is very, very painful to have any of those, the weak bone things, osteogenesis imperfecta, the JRAs, the what is it that old ladies get? I've lost my word. What? No. Well, yeah, I mean, the kyphosis, all of that is very painful. Osteoporosis, thank you. Osteoporosis is painful. All right. Hypoparathyroidism often occurs after surgery to get rid of the thyroid. Remember, they accidentally take it out. Or the parathyroids. Trousseau's sign. Now, we've got Chavostics, which if you tap on their cheekbone, their face is going to twitch. Trousseau's, you put a blood pressure cuff on their arm, and when you pump it up, their arm, they have no control over it, and their arm just kind of does the Hulk on them, and it just squeezes up like this, and they can't stop it. They may have the tingling in their toes and their fingers in their mouth. They may have laryngospasms, because you've got to have that calcium to prevent that. They may feel very apprehensive, and they may say, I feel like I'm going to die. Again, we should always listen to that, right? Severe hypomagnesia, so a severe drop in your magnesium, can actually cause a suppression of your PTH secretion. So obviously they're going to have labs that go in with this, a CMP, CBC. They're going to do the works on them to check and see what's going on. Because it's not always just all about the calcium. Your other minerals affect all of your minerals. So, you want to observe them carefully for the tetany. IV calcium gluconate. Remember how long we're going to give that over? 10 to 20 minutes, exactly. You have to watch the patient on the calcium gluconate very, very carefully. Watch their IV like a hawk, because even though it's only 10 or 20 minutes, if that IV is not in good and it has extravasation, it can cause tissue necrosis, and they will end up sloughing off a huge part of their arm. And if it's really, really bad and you weren't paying attention, they could even lose part of that limb. So be very careful with extravasation on the calcium gluconate. If they are having trouble with their pH because of the calcium imbalance, you can have them rebreathe into a paper bag, and that'll help balance it out a little bit more. They may need mag sulfate, because remember, if they're severely depleted in the magnesium, their calcium may be off. Patients on digoxin are vulnerable to this. Not sure why, but they are. Once you get them stabilized, get that IV calcium in them, get their calcium levels stabilized, they're going to have to be on calcium and vitamin D for life, especially if they've had a parathyroidectomy. This is not optional. So, and I've seen patients who just, especially teenagers, like, oh, I don't have to take it today, I'm busy, or they just forget. It's not intentional necessarily, because calcium's not expensive, right? No. Even the prescription calciums are not that expensive. So mostly it's just a matter of forgetting to take your meds. So education on how important it is to take those meds. Oh, now we get to my favorite part. All right. Pancreas. Now, you know your pancreas is responsible for a lot of things, right? It's responsible for all these enzymes. Well, if the beta cells in your pancreas quit working, you end up diabetic, right? Now, when a patient is in the hospital and they're on insulin, I think most people in the beginning assume that they are type 1. Is this necessarily true? No. In the hospital, if you are type 1 or type 2, they want to keep very, very careful control of your diabetes. So almost everybody in the hospital is on insulin. So 4-time-a-day blood sugars, insulin before the meal, insulin after the meal for their carbs. Ideally, you would want to put their 2 insulins together so you only had to do 1 shot. You can do that at home a lot of the times because you kind of know how many carbs you're going to eat. You know this plate has 60 grams of carbs on it. You know if you're going to eat the whole plate. So you take that blood sugar before they eat, and then you look at the carbs, and you can combine them into 1 shot. That's ideal. And why do you want insulin on board before you eat? It mimics the action of your pancreas. All right? When we smell food, when we're about to eat, our brain switches on that signal to the pancreas that says, hey, I'm going to eat. So the pancreas starts secreting little amounts of insulin before you even start eating. So ideally, you should have your insulin before you start eating. In little kids, that's hard to do because you don't know how much they're going to eat. And then if they're sick, you also don't know how much they're going to eat. So you can at least do their correction factor before they eat and then go back and do their carbs. So, let's say we didn't get our insulin, and now we're in severe hyperglycemia. You got 2 different kinds. You've got your DKA, diabetic ketoacidosis. This is almost always type 1s. Some adolescent type 2s will come up in DKA, but the older you are, the more it goes over to HHNS. Okay? So, DKA is typically type 1, occasionally the young type 2s. It has a very rapid onset. If you forget to take your insulin or you forget to take your Lantus, your long-acting insulin, think LA, long-acting Lantus. And then you don't give even one correction factor or check for your carbs, you can actually go into DKA pretty quickly. Now, blood sugar over 250 with ketones. There are plenty of people who walk around with their blood sugar in the 400s with no ketones. They are not in DKA. They're just having a really rotten day. They probably have a headache. They're probably very thirsty. Probably urinating a lot because they're drinking a lot to try to flush out all that excess glucose, right? All right. The difference between a blood sugar over 250 and DKA is the ketones. If they have the ketones, then they're in DKA. Now you've got your different stages, and we'll talk about that in a second. Now, HHNS, that's your type 2 diabetics, but HHNS does not typically have ketosis. It's a very slow onset, anywhere from 2 days to even maybe a week. Very slow, very insidious. Blood sugars over 400, by the time they come to you in HHNS, they're very sick. So it has a pretty high mortality rate. I put this handy dandy little chart in here just because you can kind of see the difference. You've got your mild DKA, which most of the time can be managed at home. Moderate DKA can probably be managed at home, but the severe DKA, pretty much they need to go to the hospital, get fluid resuscitation, get some insulin on board. The big deal is that in HHS, no ketones to small or trace. Blood sugar is going to be pretty darn high, and you can see the difference in the pH. The pH is really going to change, right? Yeah. Did I talk about? Oh, okay. Hadn't gotten there yet. So let me think about how I want to approach this. I don't want to do that yet. Okay. Just going to this one. So what causes DKA and HHNS? A lot of times it's just plain out old, they were sick. The patient's sick, they can't manage their fluids, they can't manage their food. They maybe don't take any insulin because they think, well, I'm not eating, so my blood sugar shouldn't be high. But you still need a basal amount no matter what, correct? And you also, when you get sick, what happens? What do your adrenal glands do? Your adrenal glands send out cortisol. Cortisol raises your blood sugar. So when you're sick, your blood sugars are going to be a little higher. That raises your blood sugar. Now, we know your body doesn't heal as well when your blood sugars are high, right? Exactly. Secondary infections and bacteria love high blood sugars because they feed on that sugar to grow. So think about it. This is why we want to keep really tight control of our patients in the hospital, because the more in range their blood sugar is, the less likely they are to come up with secondary infections. You want to teach your patients to check their blood sugar every 2 to 4 hours when they're sick, because it sneaks up on you in a hurry. You can actually have ketones with low blood sugars too. You think of it as a high blood sugar, but basically your ketones, you're having ketones when your body doesn't have access to sugar, correct? So if you're too low, your body doesn't have access to that glucose you need. And if you're too high, it's because you need more insulin. You need something to unlock that cell. So think of insulin as the key that unlocks the cell that allows that glucose in. Okay? Very, very common to go into DKA when you have the flu or any other viral illness where they can't keep up with their fluids. Still got to check your blood sugar, still got to give a correction when that blood sugar's high, even if you aren't eating. All right? Really common for people who've been drinking to forget their insulin. But alcohol also raises your blood sugar, so that can be an issue when you're diabetic. Pancreatitis, basically that pancreas is irritable. Now this can be pancreatitis. You don't have to have diabetes to have pancreatitis, right? So you actually, if you had a really bad case of pancreatitis, you could have DKA and not be diabetic. Now it's transient. If they fix it, it's going to go away. It's not permanent like someone with type 1. The biggest cause of DKA is noncompliance with the medication regimen. Forgetting that long-acting insulin. Honestly, if you don't do anything else, but you take your long-acting insulin, you probably won't go into DKA. Now, that's not a guarantee, but if you take that long-acting insulin, it puts out just enough of a basal rate to keep you from going into DKA. You wouldn't go into HHNS because you're not type 2. So, nope. Non-compliance is the biggest reason for DKA. All right. So, wait, I already did that one. So with DKA, they're going to mimic some of the signs and symptoms of shock because they're dehydrated. And they're dehydrated because their body's trying to flush out all that extra sugar, correct? So they're drinking themselves silly. But being in DKA makes your GI tract really irritable. So you may not be able to hold down fluids, which may lead to more dehydration, correct? All right. They've got the Kussmaul breathing. They're breathing really quickly. They're trying to blow off that excess carbon dioxide to balance out their pH. They smell like juicy fruit gum. So, and that's pretty later. They might start blowing off they may start breathing quickly and be able to handle it that way. But later on, as it gets more and more severe, that's when they get a little fruity. Sometimes you open up the door and you go, whoo, somebody's been drinking too much in here. And it's actually just the acetone smell from them trying to blow off that carbon dioxide. They may be confused because their electrolytes are off. Obviously, they're going to have abdominal tenderness because their GI tract is irritable. So what happens? Okay, let's say you've got an insulin deficiency. This actually causes the body to produce more glucose, which results in an even higher blood sugar. Now, this leads to even more diuresis, which then severely depletes your sodium, your potassium, your chloride, your magnesium, and your phosphate. So not only are you dehydrated, but now your electrolytes are all out of balance. Eventually, without treatment, the patient can go into a coma, which is an issue, obviously, and if not treated, death is inevitable. So the patient who has DKA, who's not treated, typically has a really severe headache. And you think of this as a sign of dehydration, correct? And that is correct. But what happens with DKA is the brain actually starts swelling. It's kind of a reverse osmosis type thing. The brain starts swelling, which is what causes that headache. Untreated DKA actually can lead to the brain getting too big for the cavity. And it has nowhere to go except down through the foramen ovale. So untreated DKA results in brain death because it just basically pushes your brain down through the foramen ovale, which causes, of course, irreversible brain damage, death. Because that's right there where your hypothalamus is. That's right where your breathing, your heart, all your autonomic systems are. So obviously that's a problem, right? Now, see what I messed up. I didn't do. I pretty much got it all. You know the little dipsticks, right? Those are a very quick and easy way to test for ketones. They actually have little blood ketone strips. Those are fine, but they're kind of expensive. The urine strips pretty much do the same job, and they'll tell you very quickly whether or not your patient's in DKA. And they're peeing like crazy, so it's not a problem to get a urine sample. Now, HHNS is DKA without the ketones, typically in older type 2 adults. Number one reason for it, again, is medication noncompliance, but it sneaks up on them. The dehydration in HHNS is actually even worse than in DKA. So the first thing you're going to treat for a patient in HHNS is the dehydration, right? They may be confused. They're having abdominal and leg cramps because their electrolytes are off. They may not even be able to speak. Of course, at some point, your DKA patient's not going to be able to speak either. Their blood sugar's too high. They can't. They're confused. The electrolytes are off. Their blood sugar's too high. They can't think. The symptoms are basically the same. You're going to do a blood sugar if it's really, really high. It matters if they're type 1 or type 2, but not necessarily initially. Okay? Hydration, number one. So let's see.
Does that mean if you have a patient that was in the HHNS, if you had a choice, I guess, what you do first, you would be giving fluids before you be giving the insulin?
We're going to talk about that, but fluids come first in both.
Okay.
Fluids come first. Hydration is probably the most important thing that you can do because that's going to help rebalance their electrolytes. They're severely, severely dehydrated. You can't flush out extra glucose if you don't have anything to flush it with, right? So basically with HHNS, you're going to figure out why they're in HHNS and treat it. It may be that they're sick. It may be they've got some kind of virus going on. It could be that they just forgot their medicine or ran out of their medicine. Say you've got an elderly person who can't get out of the house and there was a snowstorm, so the people who deliver their medicines couldn't get there. And then a few days later, it was forgotten about. So it's very insidious, very slow. Figure out why they have that and then treat it. You are only going to start insulin after you have rehydrated. Okay? You know why? What'd you say, Haley? An imbalance in your blood sugar actually messes up your potassium. And when you rehydrate, the patient who initially looked high in potassium, because they were dehydrated, may actually be low in potassium. But when you give insulin, it pushes it back into the cells, so they may actually be deficient in potassium and end up in a cardiac arrhythmia because they were hypokalemic. So you have to rehydrate first. Then you get labs and check where their potassium is. After that, you can start insulin. So I've got a great little mnemonic. We'll talk about it in a minute. Potassium is usually going to be replaced with 20 milliequivalents of potassium per liter. And you remember, you're going to be hydrating them pretty rapidly. Sometimes they'll just, not even put it on a machine, just open the, what's it called? The what? Yeah, the roller clamp, thank you. Sometimes they'll just open that roller clamp, get that 1,000 mils in you as fast as they can. Just push it in, push it in, push it in. And it may take a couple of liters to get you rehydrated. Let's see. You're only going to switch to sub-Q insulin after their blood sugar is less than 200 and they're eating. So they're going to get an insulin drip until their blood sugar is down and they can eat. Both. All right. Again, you're going to replace that potassium before you start the insulin. That's a big one. You may have to check their blood sugar every hour and titrate your doses. You don't want the blood sugar to drop more than 50 to 75 milligrams per deciliter every hour, because dropping it too fast can also cause that swelling in the brain. So you actually have to bring them down slowly. Now type 1, obviously, we're going to rehydrate. Again, we're going to replace that potassium before we start the insulin. And then your insulin is going to be 0.1 units per kilogram per hour. Remember that. That will come back to haunt you. Again, your ideal drop is 50 to 70 per hour. You're going to check their blood sugar every hour. If it's going too fast, you're going to titrate it down. So it may go from 0.1 to 0.09. And then the next hour, it may go to 1.1. Depends on how fast their blood sugar is dropping. And the doctor will give you orders. So it's not like you have to guess. Or, actually, most units have a protocol. And you just go by the protocol. So, they only get bicarb if their pH is less than 7. Because otherwise, as you rehydrate, as you get the insulin in them, they will automatically go ahead and fix their pH. If you can't remember what order to give it in, my little mnemonic, no kidding, insulin always helps. N for normal saline, K for potassium. And then after you've given that potassium, you got your insulin. Antibiotics, if the reason they went into DKA is that they were sick. And then the H is for bicarb, because you know it's HCO3. You're like, that should be B. All right? So no kidding, insulin always helps. But not until you've given saline and corrected their potassium, right? Exactly.
Make sure you say it one more time, please. Will you go over it?
No kidding. Insulin always helps. So N, normal saline. K is potassium. I is insulin. A would be your antibiotics if they're sick. It could be that they just forgot to take their insulin. That happens. That was my cell phone, sorry. How rude. And then H is bicarb. Okay? And that's the order you go in. Rehydrate first. Rehydrate. That's the number one thing. Rehydrate. Titrate that insulin. Okay. Let's see, what did I forget? All right. So you're going to check their vital signs pretty regularly. Their level of consciousness may fluctuate, especially if they had really severe DKA or HHNS. They're probably comatose or close to it, very lethargic, very slow answering. So you're going to see, does their LOC come up? Does it change? Urine output should change. Obviously, it should come up because now they're rehydrated. You're going to check them every hour until they're stable, and then every 2 hours. Okay. Once you get them below 200 and they're able to take food by mouth, you're going to give them sub-Q insulin 1 to 2 hours before you discontinue the IV insulin. Now, why? Because you've got to have that insulin on board. Exactly. All right. So, after their foods have been started, you want to make sure you've got their right correction factor and their right carb ratio. Now, different hospitals do it different ways. I know Integris has the X and Y factor. X is your correction factor. So it's usually a ratio. So it'll be, there's nowhere to write in here. Oh, here, Jackie. You get to do this. Otherwise, OPS you can't see. Okay. Oh, I should take the microphone. Otherwise, OPS you can't hear either. typically somewhere around 1 unit for every, they usually are 20 to 25, 20, let's say 25 points above 100. Because they want to keep a very tight control. They want to keep you as close to between that 70 and 120 as possible when you're sick and you're in the hospital. You feel better. You don't feel well when your blood sugar up. So before they eat, you're going to go in and check their blood sugar. Let's say their blood sugar was 200. Okay? That's not hard, right? If it's 1 unit for every 25 units above 100, you're going to take 200, subtract 100. This is hard math. That leaves 100, right? 1 unit per every 25, so 100 divided by 25 is 4. So they're going to get 4 units for their correction factor. It's not hard, but when you see it expressed as a ratio, sometimes that throws people. Saints does it as a sliding scale. It's not quite as tight of control, but it's kind of the same thing because basically if they say 1 unit for a blood sugar of 100 to 125, that's still the same thing, right? Yes, exactly. Now, so X is what they call it integrous. At OU, they do it expressed as a ratio, and they'll say CF. So they actually say CF for correction factor, and that's going to be the one that you give for their blood sugar. Now, their carb ratio, they say it as CR, is basically how many units of insulin you give them for their carbs. It can be, for younger kids, it's anywhere 1 to 25 carbs. Older people have a harder time managing their blood sugar. So theirs may be as low as 1 unit for every 4 carbs. That's a lot of insulin, right? It is a lot of insulin. But it just depends on the person and how brittle they are. There's really actually no such thing as brittle. People say I'm a brittle diabetic. I mean, it can be really hard to manage. But you've got to figure out what your ratio is. You have to figure out what foods set you off. Some people just flat can't eat donuts. I mean, because here's the thing. When you're type 1, you can eat whatever you want as long as you give yourself insulin, right? Type 2 is actually a little harder because type 2 is controlled with diet and oral meds for the most part. Type 1, as long as you figure out what sugars your blood sugars are really high, you can either avoid it or you know to adjust your doses. Now, you're not supposed to adjust your doses without your doctor. Most adults do. So know that. Okay. But if I said your correction factor was 40, what would that mean? 1 unit of insulin. 1 unit of insulin for every 40 points above the defined parameter. Usually 100 in adults. In kids it's different. So you're just going to remember to divide by 40 after you subtract that 100. Okay? Now if I asked you what your total dose was, that would mean I was asking you to give me the number for the correction factor and the number for the carbs. So you have to remember there's the correction factor, and that's what you give for the actual blood sugar, and the carbs are what you give for the food that they're going to consume.
So we just take however many carbs they have.
Yeah, the carbs is easy. You just divide by the number of carbs that they consume. Now, say you took someone's blood sugar at 2 o'clock, or say 11 because that's before lunch, and then you gave them their insulin, and then for some reason you decided to take it again at 1 or 12:30. And their blood sugar was above the parameters. Would you give insulin again? No. Because then you're stacking their insulin. you can't give insulin more than every 2 hours, or at least regular insulin, because then you're stacking that insulin, and then eventually it's going to catch up with them, and they're going to have a severe low. So then they have their severe low. They eat everything that they can get to. They'll chew their own arm off because they're so hungry. Because you know how shaky you feel when your blood sugar's low? Well, that in turn causes the blood sugar to go high. And then you check that blood sugar and you give more insulin. And basically what you're doing all day is chasing blood sugars, chasing blood sugars, chasing blood sugars. So know the parameters on how often you can give the different kinds of insulins. Regular insulin, no more than every 2 hours for a correction. Okay? All right. Obviously, if they're not on a pump, you're going to give them a long-acting insulin. So you take them off that insulin drip. They're back to the parameter you want them to be in. They're less than 200. They have cleared their ketones. You're going to have to give them a long-acting or a basal of insulin. So that's going to be your Lantus or your Levomir. That just squirts out just a little bit all day long. Now, patients who've had diabetes for a long time or who have been stable will often have a pump. And basically that pump gives you just a little basal rate all day long also. But it's regular insulin in the pump. It's not long-acting insulin. It's just regular insulin. People on pumps can actually regulate their blood sugars quite a bit better because they can go ahead and give themselves, so say they're going to eat, but they're not sure how much they're going to eat. They can go ahead and give themselves the correction factor without having to poke themselves. And then when they get done eating, they do have insulin on board for their correction, but then they can go ahead and give the rest of the insulin for their carb ratio without having to give another injection. So you can see how an insulin pump would be pretty handy. So, however, if you have someone on an insulin pump and their blood sugars are going up, and their blood sugars are going up, and their blood sugars are going up, you have to make sure the tubing hasn't kinked, that the catheter that's inserted under their skin is working. So if they've given themselves a correction and it hasn't worked, and they've done it again and it hasn't worked, then they need to change out all of their tubing and start over from the beginning. Okay? The big thing on this is going to be education. Education, education, education. Did I say education? Yeah. Because it's important to get that insulin on time. It's important to remember it. Now, insulin that's left out in extreme heat or in extreme cold goes bad. Once it's gone bad, it's no good for you anymore. Once it's been opened over 30 days, once you've accessed it, after about 30 days, it just starts losing its potency. So you want to also educate your patients on getting rid of old insulin. Okay. Look, I even got a question for you. I'll let you guys figure that out. I love it when I've already talked about stuff. Here's a really easy one, but you can expect to see questions like this. He weighs 90 kilograms. He's ordered 0.1 units per kilogram per hour. How many milliliters per hour should Mr. Smith receive of insulin? Oh, yeah, you're right. Yeah. Sorry. I was like, no. What? 9. Yeah. Just take that decimal, move it over. So, these are not hard. These are not hard. Now, the patient with diabetes who is hypoglycemic is actually in worse shape than the patient with hyperglycemia. We think of DKA as bad, right? But DKA is reversible with treatment. However, the person with hypoglycemia doesn't have any glucose on board. And your brain's got to have glucose to function. So if you don't have any glucose on board, your brain is essentially starving to death. So signs and symptoms of hypoglycemia, they're going to get really crabby. They may cry at the drop of a hat. They'll be shaking. They'll be diaphoretic. Very hungry. Severe seizures and coma. Have you ever heard the expression cold and clammy, give them candy? Hot and dry, sugar's high, cold and clammy, give them candy. So if you touch them and they feel sweaty but their skin is cold, they're probably hypoglycemic. Now if you came into a room and you saw someone and you knew they were diabetic and they were out cold and you couldn't check their blood sugar, which direction would you go? Hypo. Absolutely. Because if they're already hyper, getting glucagon in them, so an emergency access of glucose, it's not going to tip them over the edge into death. You've still got time to correct it. However, the person who is severely hypoglycemic without treatment will die. So if you're not sure which way to err on the side of caution, give a little glucose and then figure it out from there. Because you don't have as much time as you would like. Seizures are very common with hypoglycemic patients. If they're severely hypoglycemic, they're going to have a seizure. If they're hypoglycemic and they can swallow, if they can rationalize with you, if they're, alert and awake enough, you're going to give them 15 grams of the quick-acting carb. That's a half a cup of juice or a regular soda. That is 3 Starburst or 14 Skittles. It sounds simple. Now, they're going to want to eat the whole bag, right? Because they're hypoglycemic, so they want to eat the whole bag. But then what happens? If they eat the whole bag, what are you doing then? Besides falling out of your chair. Too much alcohol last night, Annie? She's hypoglycemic. Somebody quick, get some glucagon. If they eat the whole bag, then they're high. So then you're chasing blood sugars all day. Recheck their blood sugar. Your book says 15 minutes. I'm going to have to tell you, experience is more like 25 to 30 before that blood sugar actually starts showing that it's come up. Yes, ma'am?
Can you not do, I just remember this question last semester, can you not do milk, like skim milk, better than soda? You guys remember that? You can, but typically if you're hypoglycemic, you're not at home near the refrigerator, right? So it's harder, and milk has protein in it, and you don't want to give anything with protein until you've gotten the sugar up.
The soda question last semester was diet soda compared to milk, so that was mine.
Oh.
That was why I said that.
If milk is all you've got, go for it. Your best alternative is juice. I mean, soda's just, you get nothing else out of it. Now, it'll help get the blood sugar up. But anyway, after they get their blood sugar up, then you can give them a protein, which is going to help them keep it up. So they want to keep some peanut butter crackers around, peanut butters, little cheeses, something like that. If their blood sugar is less than 80 after that 15 to 20 minutes, then you're going to retreat with another 15 grams. And you're going to keep doing that until their blood sugar is above 80, at which point then you're going to give them a protein. All right. In the hospital situation, you usually have an IV line, right? You hope. So if you have an IV line, glucagon is, D50 is your drug of choice because it is really quick. And if you've ever messed with D50, it is so thick. You can wash your hands for 2 hours after you get D50 on your hands and they're still sticky. It is just like sugar, 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 sugar. Very, very high osmolarity. So extravasation is a problem because it can damage the vessels. That's why you don't want to give D50 very often because it can actually kind of eat the little blood vessels. However, it's very quick. Very, very quick. Now, if you're away from the hospital, if you don't have access to D50 or if you don't have access to an IV, glucagon is your best friend. And glucagon gets that blood sugar up. However, they're going to throw up.
So typically, they're going to have to go to the hospital anyway to get rehydrated so that they can take in food so they can keep their blood sugar up. Because if you're severely dehydrated, you're going to get nauseous. But something about those blood sugars being off makes that GI tract really irritable. And then you give the glucagon, and it makes it even more irritable. So now they can't hold down food. So then you're going to have to get them to the hospital, get some glucose going in their veins, etc. Now, not everybody. I mean, some people can take the glucagon and bounce right back, but just expect a little nausea and vomiting and tell them to go ahead and go to the ER. One of the big causes is failure to eat after they got the insulin on board, or an overdose of insulin. That can happen. You know, insulin pens are kind of hard to see. We actually had a nurse at Children's. Okay, here's my safety tip for the day. When you calculate your insulin doses, in the hospital you have to have someone check your insulin with you. And you say, I'm giving 16 units of regular insulin. And they look at it and they go, yep, that's 16 units. Okay, legally that's what you have to do. But a good nurse is going to say, this is his blood sugar, this is his correction factor. Here's the carbs. I'm giving this much insulin. And they will make another nurse check their math. We actually had a nurse at OU give an 8-year-old boy 60 units of insulin. Because she calculated his insulin based on his carbs and not on his correction factor. No, I'm sorry, on his calories. She did it based on his calories. So he had 600 calories. She gave him 60 units of insulin. And the nurse who checked behind her said, yep, that's 60 units. Neither one of them went, 60 units? For an 8-year-old, that seems excessive. So that kid obviously ended up in the ICU on a glucose drip until we could get his blood sugar stabilized. So remember, it's not just about checking that number. It's also about checking their calculations. Insulin's not something you mess with. Occasionally, the pancreas is over-functioning, and they give octreotide, which we talked about it in class on Thursday. It's a sandostatin. It helps if they're producing too much growth hormone. But it also is mostly used for hyperinsulinism. So for people whose pancreases are over-functioning, they'll give octreotide. Well, octreotide lowers that release of insulin, they have hyperinsulinism. They put out too much insulin. So the treatment for it is octreotide, which lowers the insulin, okay? They may even remove the pancreas, although that's unusual. But I have seen it done. In really, really, really severe patients, they will remove the pancreas. That is it, boys and girls. I will see you Thursday. We will have cash cab. Everyone will be wearing pink. And you will do everything that I command you, just like I hypnotized you, right? Maybe.